I mean, I have quite a broad view of this, I think. I mean, we can think of roles that are entirely new and they've not been there before,
Yeah.
and we reconstruct them, and that's kind of, in a sense, the purest version of it. But I think what I see also, though, is the roles that have been broadened,
Yeah.
sort of job enrichment, if you like.
Yeah.
Roles that, so actually not higher levels necessarily, but doing things they may not have done before, the level they previously worked. And also, when you're not creating maybe a higher level role, but sometimes higher level tasks, and I work mainly around the unregistered workforce. So it's almost like sort of a cross, isn't it? You can move up, you can move along, and sometimes tasks get delegated downwards as well. So I've got quite a kind of broad view of what we mean by new roles.
So not necessarily brand new, just different.
Different.
So what would be the drivers then to actually develop a new role? What would drive us to do that?
There's got to be something around what the needs of the patient are. You know, looking at how technology is changing, how the care of the patient is changing in hospital or in community. They're often much more acute with often comorbidities. It's about, sometimes the registered job isn't quite knit with the particular needs of that patient. So it's about developing something that a new person can do that supports different stages of the pathway, or different treatments or care that patient might need.
I think it's also about looking at your organisation and your skills within that organisation as one. I think it's not about separating necessarily what's registered and what's not registered, but actually looking more globally and thinking about career pathways for people too.
From my point of view, the technological changes in ophthalmology, which have been happening over the last 10, 15 years, for example, tests that were usually done by the doctor, because the actual kit has come along so far, it doesn't have to be a doctor that does the test. So from my point of view, it's picking out tasks that can be done so the patient experience is much improved.
Okay, so much of the conversation we're having now is about quality and about improvement for the patient.
Yeah.
But one of the things that gets thrown at me is it's all about the menu. What's your view on that? It's all about making it cheaper.
I think it has to always be about the patient. And if I sit with two heads on, because I'm a nurse by background, and obviously now I work in workforce and OD, and I do have some responsibility around those financials, I think it's always important to make sure that we don't lose sight of what we're doing it for, and that is the patient. And if we can use the evaluation methods to determine what the cost savings might come out of that, then all the better.
And I think it's about sometimes the experience for the individual, because again, clinical nurse specialists is a good example of where we've had these roles for some time. When you talk to patients and they all know the benefit of having one, but we still every so often, especially when it gets financially a bit tight, people then start saying, well, what do I do in a CNS? They're expensive, what do they do? So I think it's got to be done in a meaningful way. It's got to be based on, what the patients, what the clients are telling us, in terms of what they think the value is.
I think sometimes people get hung up about the pounds and the pence, but at the end of the day, it's the impact or the improvement it's made on the service or the patient, and quite often they're the people to talk to who will demonstrate and articulate how much of a difference it's made for them in that experience.
And value that, because often,
and value it, yes.
because I think sometimes we don't do that. We look at the money, and again, that's one of the criticisms of Francis, isn't it?
Yeah.
People have been so focused on the money and the targets rather than the actual experience and outcomes.
Yeah, I don't think we can avoid the issue of the money by saying, well, really we want it to be service driven and it's about quality for the patient and patient care, because a lot of these things, when you introduce them, it will be front loaded at the beginning, because you are necessarily first of all doing the work about finding what the new role should be and working out how it's going to fit with the service, where it fits in the workforce plan and all that stuff. You're identifying education and training, and that amount of work at the beginning is taking your time out from the service, from actually doing service delivery.
With the role changes that I've undertaken, that was about a large group of CNS level nurses who had very different skill sets amongst them, and it was about identifying that and actually working with them to be able to talk to them individually to say, actually, we're going to rename this role, it's going to be nurse practitioners, and there are going to be 3 different levels, so going from both associate nurse to nurse practitioner to advanced, that actually then there's an understanding throughout the organisation of what expectations are with those roles.
Education isn't just about providing knowledge, skills and values and attitudes that are required to do the job competently. It also actually builds on those competence issues. So in my experience, and again I'm talking from an unregistered staff point of view, but I'm sure it'll be true for advanced practice and other roles as well, if a role is being trained, if there's a workbook, if people are clear what the boundaries are and they can see people acquiring those knowledges and those competences are signed off, that builds up confidence to delegate. Actually raises the profile of the role as well, which can be quite an issue.
I've learned such a lot by working with somebody. I've had my training, but then putting that into practice, and then working with somebody that's got the experience. That I think sometimes you learn more as well by actually doing something practical, working with somebody side by side, learning how they work, and then that's where you get your knowledge and you enhancing your skills then, like I have done with Alice and the other therapy team, the physios.
I think it's really important that education comes in at the start with when you're looking at roles, when you're looking at JDs, because actually it needs to fit in with whatever assessments you're doing, with the HR processes around competencies, around gaps, and actually that's when your education team need to know what your vision is and what you're looking for, so actually they can be providing those bespoke gaps if that's necessary.